My name is Aruni Kanolkar, and I'm from the University of Iowa Hospitals and Clinics, and I would like to thank the ASCP for this opportunity to present as part of the Path to Atlanta webinar series. And I am giving this presentation on behalf of the Association of Medical Laboratory Immunologists, which is one of the partner organizations of the ASCP. And based on the feedback that ASCP provided the AMLI team, one of the topics in immunology that the potential attendees were interested in hearing about was GVHD. So I'm happy to oblige, and I'm going to talk about GVHD, but with a little bit of a twist. So the title of the talk is An Unexpected Case of GVHD in an Infant and Lessons Learned from a Natural Transplant. There are three learning objectives. I think the first learning objective is to understand or describe to you the concept of maternal T-cell engraftment. The second learning objective is to discuss the immunological and genetic workup of a patient with maternal T-cell engraftment. And the third objective is to interpret the tests that confirm maternal T-cell engraftment. So before I actually begin the presentation, I just want to mention that I have no financial relationships with ineligible companies to disclose. And so this was a case from a few years ago that came to Lurie Children's Hospital in Chicago, where I was just before I moved to the University of Iowa Hospitals and Clinics last year in July of 2024. This was a full-term male baby who was delivered by C-section to parents of Northern European descent. There was no family history of consanguinity. And the baby, for the first few months of life, met all the normal developmental milestones. But there were a few sort of instances which necessitated medical intervention. In the second month of life, the baby developed acute right mastitis, which required hospitalization and IV antibiotics for 2 days, followed by oral antibiotics, which led to the resolution of symptoms. In the fourth month of life, the baby developed upper respiratory tract and lower respiratory tract infections, which again required PICU admission, and the baby was put on a ventilator and received IV steroids and antibiotics. And finally, and third event which necessitated sort of transfer of the baby to Lurie Children's Hospital was in the fifth month of life, which also coincided with the baby receiving the live attenuated pentavalent rotaviral vaccine. And the patient, after receiving the vaccine, the baby started to develop persistent watery diarrhea that lasted 5 weeks, and it was quite severe. The baby had about 10 bowel movements per day. And the baby was admitted to an outside hospital, and in the outside hospital, they actually did a workup to looking up for respiratory viral panels. The baby was positive for rhinovirus and enterovirus, as well as one of the endemic coronaviruses, not the SARS coronavirus. It's one of the 4 endemic human coronaviruses, which a lot of people are positive for. He was positive for these viruses. The stool was negative for the antigens that they look for C. diff and rotavirus. But what was interesting was that in terms of the immunological investigations, they found that the baby was hypogamma-globulinic. He had low IgG and IgA. And at that point, the patient was transferred to Lurie Children's, which is a Jeffrey Modell Center for immunodeficiency diseases. And when the patient was transferred to Lurie Children's, we did the initial usual testing with CBC and diff, which showed that there was a slight dip in the proportion of lymphocytes in the diff, and the proportion of neutrophils was slightly elevated. But other than that, it was there was nothing really unusual there. The baby underwent a battery of tests. Again, the respiratory virus panel, which was positive for the OC43 coronavirus, as well as the rhino and the enteroviruses. The stool specimen was essentially negative for a lot of the antigens and the bugs that you see listed out here. There was no growth in the ear aspirate culture, and the EBV and CMV plasma DNA levels in the plasma were below the limit of detection. Going on to the microbial serology, which was also performed, the baby was IgG positive for a number of the common herpes viruses, such as EBV, HSV1, and VZV. Likely, this was actually maternally transferred antibodies. The baby was negative for CMV as well as HSV2. And because of the severe diarrhea, a duodenal biopsy was performed, which displayed evidence of chronic inflammation and numerous infiltrating T cells. And the histopathologic picture was almost a little bit reminiscent of what you would see in the case of celiac disease. And there was no evidence of any sort of microbial pathogens in the duodenal biopsy. The sigmoid colon and the rectal biopsy were completely normal and were unremarkable. We repeated the quantitative immunoglobulins in this patient, and you can see his IgM and his IgA and the IgG levels were all below the limit of detection for the patient's age, which was between the ages of 4 to 5 months. And so this revealed, and this actually confirmed what the outside hospital had seen, where they had detected low IgG and IgA. So the patient was severely hypogammaglobulinemic. And what it also suggested was that the maternal antibodies had waned, because maternal antibodies generally last for about 5 to 6 months and then gradually disappear. So the maternal antibodies had waned and the baby was not generating any of his own antibodies. So this is a 6-month-old male baby with no antibodies. And the first thing that comes into your mind is, could this baby boy have X-linked A gammaglobulinemia, which is an X-linked disease and it only affects boys? So X-linked A gammaglobulinemia is one of the first primary immunodeficiency diseases that was identified in the human population back in 1952 by Colonel Ogden Bruton, who was a U.S. Army physician. And what he had noted was it was a young boy who had a history of repeated upper respiratory tract and lower respiratory tract infections with encapsulated bacteria. And at that time, of course, we didn't have some of the sophisticated diagnostic tools that we do now, but in the serum protein electrophoresis, Dr. Bruton had noted that the baby lacked the gamma globulin fraction, which means the baby was not producing any antibodies. And that's because, and it took about 40 years after Dr. Bruton's seminal observation to really identify the molecular defect which causes the lack of immunoglobulins in these babies. And it's due to the absence of a non-receptor tyrosine kinase called Bruton's tyrosine kinase. So in a true X-linked A gammaglobulinemia baby, what happens is that Bruton's tyrosine kinase is absolutely required for B cell development. And so when you have a defect in the BTK, all the B cells are going to undergo a maturation arrest, and they're going to remain in the bone marrow, and they're not going to be able to come out of the bone marrow. And so if there are no circulating B cells, there's going to be no there's going to be no serum immunoglobulins that are going to be produced. And so we can actually now use flow cytometry in diagnostic laboratories to identify patients with X-linked A gammaglobulinemia, because we have antibodies that can detect the presence or the absence of the Bruton's tyrosine kinase protein. And so in a healthy patient, what we will see is that we use T cells as a negative control, because T cells and plasma cells do not express BTK, whereas B cells and all the other cells of the hematopoietic compartment do express BTK. But what is interesting about the B cells is that in the case of B cells, BTK is absolutely required for B cell maturation, whereas in cells like the monocytes, BTK is important for their function, but it's not required for their maturation and for their egress out of the bone marrow. So in a healthy control patient, you're going to see this nice population of BTK positive B cells and BTK positive monocytes, as shown in this blue histogram out here, where it clearly shifts from the red histogram, which is which is just the isotype control, which detects the background level of staining. And in the T cells, you see that it's completely negative for BTK expression. So in a true X-linked A gamma globulinemia patient, you're not going to have any circulating B cells. So you cannot use the B cells. You cannot, of course, you cannot use any B cells to detect the presence or the absence of BTK. But what you can use is the monocytes in the circulation to detect the presence or absence of the BTK protein. And you can see in a true XLA patient, which is not the patient that we're discussing today, you will not see any shift between the red peak and the blue peak. That's because there is no BTK protein at all. So what do we see in our patient? So when we look at our patient, this is once again a healthy control, and this is the patient that we are discussing out here. And you can see we are able to detect B cells in this particular patient. And in both the B cells and the monocytes, we are able to detect the BTK protein. So this patient is clearly not a case of X-linked A gamma globulinemia, even though he has essentially no serum immunoglobulins that are detectable. So the next step is to just look at the routine TB NK counts in these patients, just to look at quantify the T cells, the B cells, and the NK cells in the circulatory compartment of the baby. And you can do this by flow cytometry, and you can see that in the case of the patient, the T cells were reduced in number as compared to the reference ranges out here. And in particular, the CD4 T cells were really markedly reduced as compared to the reference ranges, and so were the CD8 T cells, but not as much as the CD4 T cells. In addition, the NK cells were highly reduced, and the B cells were slightly reduced. So the patient was hypergammaglobulinemic, and the patient was also lymphopenic because he had reduced numbers of T cells and B cells, and he had very low numbers of NK cells that were practically absent. And the other interesting thing to note in this particular patient was that when you looked at the expression of a particular molecule called HLA-DR, which is a surrogate marker to sort of assess the activation status of the T cells, you can see that in the case of the patient's T cells, there were a lot of the CD3 positive cells were HLA-DR positive, indicating that a lot of the T cells that were there in the patient's circulation, they looked activated as compared to the control sample where the reference range is between 3 to 9%, and in the patient it was about 45% of the T cells that were expressing HLA-DR on their surface. So when you have a patient with essentially very few T cells or reduced T cells, the first thing that comes to your mind is an immune deficiency, and specifically severe combined immune deficiency. And when you have reduced T cells, one of the sort of questions that comes into the mind of the treating pediatrician or the pediatric immunologist is that, do these T cells represent a full polyclonal repertoire of T cells? And just to explain what a polyclonal repertoire is that when in healthy people, when our T cells and B cells develop in the bone marrow and in the thymus, they acquire receptors on their surface which allow them to recognize the millions and bazillions and billions of antigens you're going to encounter throughout your life. And so that is what is called a polyclonal T cell repertoire. And so the immunologists want to know is that when you have reduced T cells, do you still have T cells that are capable of recognizing all the different antigens that you're likely to encounter throughout your life? And the reason why they want to know that is because they want to check for what is called Omen syndrome. So Omen syndrome is a genetic condition that prevents the development of a polyclonal T and B cell repertoire. And these patients who have Omen syndrome, they have a very narrow, restricted T cell and B cell repertoire, and they're not able to recognize all the different antigens that you're going to encounter throughout your life. And this condition is named for Dr. Gilbert Omen, who is currently at the University of Michigan, but he was actually a fourth-year medical student at Harvard when he first identified this condition. And so there are two ways of detecting the repertoire of your T cells and determining whether they have a polyclonal repertoire or not. One is a molecular test, which is by RT-PCR, which is also called spectrotyping, and the other one is by flow cytometry. And this is in the RT-PCR plot out here. You can see on the right, to my right, actually, you have this gel for the control where you can see a polyclonal repertoire of all the different TCR-V beta families, which just basically looks like a smear. Whereas in in a patient with a true Almond syndrome, where you have the genetic defect which prevents the development of a polyclonal T cell repertoire, you'll see the formation of several of these doublets in the different TCR-V beta families, indicating expansions, oligoclonal or restricted T cell expansions for the different TCR-V beta families. You can also detect this oligoclonal expansion in Almond syndrome by flow cytometry, because there is a kit that's available which has antibodies that can recognize all of these different TCR-V beta families. There are about 24 TCR-V beta families that can be detected by the flow cytometry test. It is not an exhaustive panel because it only recognizes about 70% of our total T cell repertoire, but it's good enough to determine whether the circulating T cells that we have in our blood, they are distributed or have a polyclonal distribution or not. And you can see in the dark blue is the healthy control sample, and you can see they can detect T cells for all of these different TCR-V beta families, and they don't appear to be unduly expanded. Whereas in the case of an Almond syndrome patient, which is unrelated to our patient again, you'll see one or two families that will be highly expanded. So that constitutes what is an oligoclonally expanded population of T cells. So what did we see in our patient? So in our patient, when we ran the flow cytometry test, once again here in this green is the different TCR-V beta families that we can assess by this flow cytometry assay. And here looking at the patient's data for the CD8 T cells and the CD4 T cells, and you can see that for all of the different TCR-V beta families, in our patient, we were able to detect the T cells. There was some minor perturbations for some of these different TCR-V beta families that are highlighted in red. They were slightly above or slightly below the established reference ranges, but there was no evidence of marked increase in the proportion of any of the TCR-V beta families. So what this suggested was that our patient did not have the Almond syndrome phenotype. So one of the frontline tests that the pediatric immunologist will always order in a patient that is suspected of immune deficiency is a lymphocyte proliferation assay. And basically what they want to see in this assay is that if we take your T cells and if we take your B cells and we expose them to a stimulating antigen which will cause their proliferation, or a regular antigen like a tetanus antigen or a candida antigen that you're going to receive through vaccination or through environmental exposure, are your T cells able to recognize them and proliferate? So that is the lymphocyte proliferation assay. And the classical sort of approach to assessing lymphocyte proliferation is by tritiated radioactive thymidine incorporation assays. You can also do this assay by flow cytometry, but this was in 2014, and we were still performing this assay using the old-fashioned tritiated thymidine incorporation assay. And essentially what you do is that you take the T cells and the B cells from the patient and you stimulate them with some of these chemicals that are going to cause the T cells and the B cells to be activated. And when these T cells and B cells get activated, they synthesize more DNA, and their cell cycle moves into the S phase of the cell cycle. And in this DNA synthesis, and as active DNA synthesis is going on, you add tritiated thymidine, which is a DNA nucleotide analog, and the T cells and the B cells that are synthesizing DNA will incorporate this tritiated thymidine into their DNA, and then you're able to assess the amount of radioactivity that is incorporated into the activated T cells and B cells, and use that as a surrogate readout of the ability of the lymphocytes to get activated and proliferate. So in this lymphocyte proliferation assay, you can see the normal cutoff is listed out here, and this is the value that we have for the healthy control sample that is always run in parallel. And these are the values for the patient where we report out the result in the form of a stimulation index. And you can see that the patient's lymphocyte proliferation assay reveals a highly attenuated stimulation index in response to all of these different stimulants that we use to assess the lymphocyte proliferation. So it told us that the lymphocytes in the baby's blood were not proliferating very well. The other test that we look at in the patient sample when they're suspected of having some kind of an immune deficiency is to look at the proportion of what we call naive and memory T cells and B cells. So naive T cells are the ones that have never encountered an antigen, and memory T cells are and B cells are the subsets of T cells and B cells that have encountered an antigen and have developed a memory to the response, developed a memory to that particular antigen, and will be able to mount a robust recall response if they re-encounter those particular antigens. And so this naive and memory T cell subset profile in our patient was very interesting because remember, this is a 6-month-old baby boy, and these children have not encountered the same amount of antigens and have not had the same level of exposure to the antigens as you would expect in an adult individual. So majority of their T cells and B cells should display what is called a naive phenotype. And so the naive B cells and T cells are indicated here in the green with the N, and the memory cells are indicated in the red here. For the T cells and for the B cells, you have the isotype unswitched memory B cells and the isotype switched memory B cells. So if you look at the patient's B cells, they look the way they should look in a 6-month-old baby, that 96% of the patient's B cells display a naive phenotype, which is the way it should look. Whereas in the case of the T cells, you'll find that more than 85% of the T cells in the baby's circulation displayed a memory phenotype. Now that is really unusual. You should not expect that in a 6-month-old baby in any way, shape, or form. So there are two scenarios in which you would be able to see a very elevated frequency of memory T cells in such a small child. Well, the first instance is when you had marked lymphopenia-induced proliferation, and this is what happens when you have very few lymphocytes and the baby is born with very few lymphocytes, but they are able to respond to the normal growth factors in a very vigorous way, because on a per cell basis, they have more than the regular amount of growth factors that they're able to encounter. And so these T cells, even though they haven't seen an antigen, they acquire a memory phenotype and they begin to proliferate and undergo what is called homeostatic proliferation. The other scenario, which is actually much more common, is what is called maternal T cell engraftment. So maternal T cell engraftment is usually what happens is when the maternal T cells cross over from the placenta and go into the baby's circulation while the baby is still in the baby is still in utero, and this is actually quite common. And the transplacental transfer of maternal T cells into the baby's circulation happens almost in most children, I would say. But in a healthy baby who has its own immune system that is well developed, the baby's own T cells are going to far outnumber the transplacentally transferred maternal T cells. And as a result of the 50% mismatch between the baby's HLA alleles and the mother's HLA alleles, because remember, the baby is going to acquire 50% of his HLA alleles from the mother and 50% from the father. So so there's going to be 50% of the HLA alleles in the baby that is not going to be matching what you see in the mother's samples. So as a result of both the quantity of the baby's own T cells in a healthy baby and the HLA mismatch, the baby's own T cells in a normal situation will get rid of or kill off all the maternal T cells. But if the baby is born without its own immune system, in that instance, the transplacentally transferred maternal T cells will have an opportunity to establish themselves and seed the maternal circulation. And so this is not something that is new. It's been known for decades. And these are just some representative publications back from the mid-1960s and early 1970s, where they had documented this case of transplacental transfer of maternal T cells into the baby's circulation. And so this is a paper from the early 2000s, almost 25 years old. It was published in Blood by this German group, in which they sort of did a study examining the transfer of maternal T cells in babies with immune deficiency conditions. And what they found was there was a substantial proportion of babies who have severe combined immune deficiency, which means they don't have their own T cells or B cells or NK cells. And in these babies, the maternal T cells that have crossed the placenta encounter an environment which is permissive to their sort of seeding the baby's circulatory compartment and remaining there. And as a result of the HLA mismatch between the baby's HLA and the mother's HLA, the maternal T cells that cross over into the fetal circulation are then able to mount a graft versus host kind of disease in these babies. But the exact reason for the persistence of these maternal T cells in SCID babies is not completely understood, but that is one of the reasons that they're able to establish themselves in the baby circulation. And these maternal T cells, if you examine them by traditional clinical laboratory-based assays of their functional sufficiency, such as lymphocyte proliferation, they tend to be functionally hyperresponsive. And if you recall, when we looked at the T cells in our baby circulation for lymphocyte proliferation, we did not detect very good proliferation. So that correlates very well with what is reported in the literature, that these engrafted maternal T cells tend to be functionally hyperresponsive, at least the ones that we are able to assess through the circulation. And so this matches very well what we saw in our patient. And so we knew at this point that our baby had an immune deficiency, a fairly severe immune deficiency. And it was possible that our baby had maternally acquired T cells. And the way you sort of diagnose maternal T cell engraftment is by performing a molecular test, which is a chimerism test, actually, in which you compare the molecular signature that is unique to the mother, and you compare that molecular signature from the mother's sample to the molecular signature you can detect in the baby's T cells and other components of the baby's blood. And so what you get is a buccal swab from the mother, and you examine the buccal swab for the mother, and what you see in the loci column that you have out here are these different genetic loci, which are markers of which you can use as a sort of molecular signature. And you obtain that molecular signature in the mother's buccal swab. You get a similar buccal swab from the baby. And if you want to determine maternal T cell engraftment, you have to purify out the T cells from the baby's circulation. And you can also purify out the myeloid cells, which are basically like the neutrophils and the monocytes from the maternal circulation, and examine the molecular signature of all of these different purified cells, as well as the cells in a sample of blood where you have not performed this purification or of the myeloid cells and the T cells. And what is clearly evident out here, you'll see, is that if you look at the purified circulating T cells that we obtained from the baby, it was identical, the molecular signature was identical to what you saw in the mother's buccal swab. And if you look at the purified circulating myeloid cells, such as the neutrophils and the monocytes from the baby, the molecular signature was identical to what you saw in the baby's buccal swab. So, and if this all looks like a big jumble of numbers and letters, I mean, just focus on this particular row out here for the X and Y. You can see in the case of the T cells are all XX, whereas the circulating myeloid cells are XY. So what it tells you is that in this baby, all of the circulating T cells are maternally derived because they're all XX, whereas all the other cells that we see out here, they are XY, so they are the baby's own, they are the endogenous myeloid cells. And so we knew at this time point that we were going to have to transplant the baby. And in order to do transplantation, you actually have to perform an HLA typing of the baby and the family members. And so this is the HLA type for the patient. This is a 6-month-old male baby. And this is from his sister, his elder sibling, and then from the mother and the father. And you can see, unfortunately for the patient, his sister was a complete HLA match. And so he ended up actually he ended up actually getting a stem cell transplant from his sister. So, but we'll get to that a little bit later. But coming back to the story of the maternally engrafted T cells, so we knew that the patient's myeloid cells were his own. We knew that the patient's T cells were maternally derived, but we didn't know about the provenance of the patient's B cells. And fortunately, we could use that. We hadn't run the purified B cell assay in the chimerism assay, but we were going to what we ended up doing was doing a flow cytometry-based assay to examine the sort of origin and the provenance of the patient's circulating B cells. And we could do that because we were fortunate, because the baby was HLA-A2 positive, and we knew that looking at the parents' HLA makeup that he had acquired this HLA-A2 allele from the father. And there is an antibody that you can use in flow cytometry to look for HLA-A2 expression. So when we looked at the patient's cells, if you looked at the patient's CD3 positive cells and looked at HLA-A2 expression, you could see that there was no HLA-A2 expression in the patient's T cells, indicating that none of the T cells in the baby were actually his own, and they had all come from the mother. And if you looked at the patient's myeloid cells, such as the monocytes, they were all HLA-A2 positive, once again corroborating what we saw in the chimerism assay, which showed that all the myeloid cells were endogenous. So they were all the myeloid cells were all his own. And when we focused on the patient's B cells, we noticed that they were also HLA-A2 positive. So all of the B cells were also his own. So the only thing that the baby did not really have of his own were the T cells. And so it was these maternally engrafted T cells that were actually causing the persistent watery diarrhea in the baby as a manifestation of a graft versus host disease. And we know that this was persistent watery diarrhea was caused by the maternally transplacentally transferred maternal T cells, because the diarrhea completely resolved after initiation of immunosuppressive therapy using cyclosporin. So if you go back to the patient's lymphocyte profile that we had done right at the beginning when the patient presented at our hospital, this was what we had determined in terms of the T and B cell and NK cell quantitations. Now, if we revisit that result, you can see that all of the T cells that you see out here are actually maternal T cells. So he basically has no T cells of his own. He has almost no NK cells, and he has a few B cells. They're slightly reduced, but they are still clearly detectable. So the patient's lymphocyte profile looks like he has T negative, NK negative, and he's B positive. So this looks like SCID, or severe combined immune deficiency. So let's go back. So severe combined immune deficiency is a genetically heterogeneous group of disorders in which, depending on the underlying genetic defect, you can have absence of either all of the three lymphocyte subsets, the T cells, B cells, and NK cells. Sometimes you have only the absence of the T cells and the B cells. The NK cells can be present. Sometimes you have the absence of T cells and NK cells, and the B cells can be present. And sometimes it's just the T cells that can be absent. And sometimes all the three subsets may be present, but there are subsets within these subsets that might be absent. So in our patient, his profile looked like he was T negative, NK negative, and B positive. So that's usually seen in the case of X-linked SCID, in which you have a defect in the gene that encodes for the common gamma chain. So this common gamma chain is a signaling subunit that is shared by receptors for a lot of these different cytokines like IL-2, IL-4, IL-7, IL-9, IL-15, and IL-21. And if you have a genetic defect in the gene that encodes for this common gamma chain, the reason why you don't end up not having any T cells and NK cells of your own is because IL-7 cannot signal, and IL-7 is required for the homeostatic proliferation and the development of the T cells. And IL-15 cannot signal as well, and IL-15 is very important for the homeostatic proliferation and development of the NK cells. And so it's an X-linked skid. This is all, of course, always seen in the case of males, but you can also have another defect which can cause T cell negative, NK negative, B positive skid, and that is in this particular molecule called JAK3. So the JAK3 associates with the common gamma chain, but it's not encoded on the X chromosome. So if you have a defect in the JAK3, this can affect both males as well as females, and this is autosomal recessive skid. So in our patient, we had T negative, NK negative, B positive skid. So it could have been either X-linked skid or autosomal recessive skid. So we ran a flow cytometry test to determine which of these two molecules, whether it was the common gamma chain or JAK3, was defective in our particular patient. So let's not focus on the T cells, because the T cells are not the baby's own, they belong to the mother. So let's focus on the B cells. So this is the result for our patient's B cells, and this is from a healthy control sample that was assessed in parallel. And here we are looking at the expression of the common gamma chain out here, which is CD132. And you can see in the control sample, 97%, all of the B cells in the control sample, as well as the control T cells, all express the common gamma chain. Whereas if you look at the patient sample, there's a marked reduction in the proportion of B cells that express the common gamma chain, as well as the level of expression, which is the median fluorescence intensity here. And the patient's B cells are highly reduced. So it looks like that there is a defect in the common gamma chain expression in the patient. When we looked at the cytosolic expression of JAK3, so the JAK3 molecule is not expressed on the surface of the cells. It's retained in the cytoplasm. It's one of the signaling molecules. It's Janus-associated kinase. So when we look at the cytosolic expression of JAK3 in the patient versus the control sample, you see there's really not much of a difference in the patient versus a control. So there is no defect in the JAK3 molecule in the patient, whereas there is a defect, whereas we do detect a clear-cut defect in the expression of the common gamma chain. So the patient does not have a JAK3 defect. So he's not an autosomal recessive skid. The patient has a defect in the common gamma chain, which is X-linked skid. And the other thing that you can actually detect by flow cytometry is you can actually assess the functional competence and the functional sufficiency of the T cells by looking at the phosphorylation status of some of the molecules that operate downstream of the common gamma chain and the JAK3 molecule. And you can do this by a technique which is called PhosFlow, which detects the phosphorylation status of these molecules, which are the STAT transcription factors, which when you have normal signaling going on in your T cells, for example, when IL-7 signals through the common gamma chain and JAK3, it is going to activate a STAT molecule downstream, which is called STAT5. And so similarly, there are other molecules, there are other cytokines that signal through the common gamma chain. They signal through other STAT molecules. For example, IL-4 signals through STAT6. So we used IL-4, we used graded input doses of IL-4 to look at the phosphorylation of STAT6 in the patient's B cells and T cells. And we also assessed a control sample in parallel. And you can see that in the control sample, look at the B cells, the T cells, and the level of STAT6 phosphorylation is very robust, whereas in the case of the patient's B cells and T cells, you hardly see any phosphorylation of STAT6. So the patient has a common gamma chain defect, as a result of which the patient's B cells and T cells are not able to receive signaling inputs from key cytokine molecules that signal through the common gamma chain, and there is no phosphorylation of downstream molecules as a result of that. And so the patient actually, when we genotyped the patient, he ended up harboring a novel missense mutation in the common gamma chain, and this was the mutation that the patient had. And the patient ended up receiving a stem cell transplant, as I mentioned, from his sister, who was a complete HLA match to the patient. And we assessed the patient 6 months after the transplant. So as a reference and as a comparison, I'm just showing you what I had shown you earlier, the pre-transplant phenotype for the naive and memory T cells. You can see in the pre-transplant phenotype, majority of the patient's CD8 and CD4 T cells had a memory phenotype, which is very unusual for a 6-month-old baby. Whereas 6 months after the transplant in the patient, you can see that the majority of the CD4 and CD8 T cells in
the baby boy are naive, which is exactly what you should see in a child of this age, which is about a year-old baby. And when you look at the common gamma chain, this is prior to the transplant. You could see that in the patient's B cells, we were unable to detect the expression of the common gamma chain. But 6 months after the transplant, you can see that we are able to detect the common gamma chain in the patient's T cells as well as the B cells. So the donor T cells from his sister had successfully engrafted and had given the baby boy a fresh set of normal-looking T cells and B cells. And when we looked at the serum concentration of the immunoglobulins in the patient 6 months following the transplant, you could see that there was complete normalization of the serum immunoglobulin levels in the baby boy. And these are the values prior to the transplant, and these are the values 6 months following the transplant. And when we looked at the absolute counts of the different lymphocytes, and this is what we had in the baby boy prior to the transplant. And remember that all of these T cells were the maternal T cells. So he essentially had 0 T cells of his own. He had very few NK cells and slightly reduced B cells. And this is 6 months following the transplant in the baby boy. And you can see that all of these are within the normal reference ranges. And all of his T cells no longer have that activated phenotype because there's no more GVHD going on. And he has his own T cells now, and they all look rested and they all look happy, and they're all the numbers are completely normal. And when we looked at the lymphocyte proliferation assay following the transplant, if you recall, prior to the transplant, all of the T cells in the baby circulation, which were actually the maternal T cells, they were highly hyporesponsive. And 6 months following the transplant, you can see that if you stimulate them with some of these molecules, which induce T cell and B cell activation and proliferation, they display very robust activation and proliferation. And when we look at phosphlo and the ability of the patient's T cells and B cells to phosphorylate the STAT molecules, in this case, we're looking at IL-4 induced phosphorylation of STAT6. You can see that in the patient's T cells and B cells, we're now able to see normalization of the STAT6 proliferation as compared to prior to the transplant, where there was highly attenuated phosphlo signature in this particular patient. So basically, that's the end of the presentation, and hopefully you have learned that the concept about maternal T cell engraftment, as well as understanding how we can assess the presence of maternal T cells in the baby's circulation that is experiencing evidence of maternal T cell induced graft versus host disease. And you've also learned about the chimerism assay, which is the confirmatory test to look for to confirm the presence of maternal T cells in the baby circulation, and how we perform different immunological and genomic assays to assess lymphocyte functional and numerical sufficiency. And I'd like to, in the end, acknowledge the Ann and Robert H. Lurie Children's Hospital of Chicago, where we performed the study to the Diagnostic Immunology and Flow Cytometry Laboratory, as well as my colleagues in the Division of Allergy and Immunology who follow the patient, as well as the Jeffrey Modell Foundation for their philanthropic funding, which enabled us to develop and clinically validate the assays that I shared with you in this particular presentation. So with that, if you have any questions, I think ASCP will be sharing my contact information with you, and feel free to reach out if you need any clarification or any additional information regarding the data that I have presented in this presentation. Thank you very much, and thank you to ASCP again for this opportunity to present.